Tuomo Tikkanen toimii tilaisuuden puheenjohtajana. Chairman, ladies and gentlemen. I will use as my opening address melancholy as a concept. I wrote my first lines in a manner trying to use Burton's way to describe different things 400 years ago. He published 1627 a book called The Anatomy of Melancholy, what it is with all the kinds, causes, symptoms and prognostics, and several cures of it. He opened his book by a poem. I took the first verse and the last. When I go musing all alone, thinking of diverse things foreknown, when I build castles in the air, void of sorrow and void of fear, pleasing myself with phantasm sweet, methink the times run very fleet. All my joys to this are folly, not so damned as melancholy. The book is written in a way which would never be accepted as a dissertation or even a master thesis nowadays. It's very confusing, 800 pages, references to everything, trying to combine all the knowledge of human mind to cure and analyze a malady very deeply experienced many hundred years ago already. There are all kinds of definitions. I simply took random. Nobody has written that. Nobody has read that book, I don't think, for 200 years. It's almost impossible to read. But anyway, with good luck, I found interesting parts. One is the description of despair. There be many kinds of desperation, whereof some be holy and some unholy. Holy ones are not to be treated. I mean, you can have a depression with good reasons. You may be pondering about the existence of God or your life. I don't see any reason why not to feel pessimistic about that. But some are unholy. They need something. A sickness of the soul without any hope or expectation of amendment, which commonly succeeds fear. And here we have a so-called self-trap. For whilst evil is expected, we fear, but when it is certain, we despair. There is no way you can escape from fear or despair if your state of mind is something which might be called melancholy. Actually, he kind of a united hypochondria and many other diseases which nowadays might be classified differently. However, self-trap is one of the features of melancholy and depression even today. I took pictures yesterday. It was a very beautiful day. One of the most beautiful days in November I have ever experienced. This is a well-known statue of wreck. The ship has been sailing in the sea, or perhaps, and then it went down in the sea. And the family was left there alone. I'm not really certain whether this is melancholy. I think it's with good reason a despair. But anyway, here you can see something of the difficulties of giving a picture of melancholy or true despair. Here it is, I would say, a genuine despair. Can we be saved? Are we left here in the Mediterranean Sea between Italy and Africa, between Turkey and Greece, or between Sweden and Finland? What happens to our children? Father was the erected one. Here you can see also the mother trying to protect her child. And the child is feeling I think, despair. Among many sentences in that book, there is a second part, the cure of melancholy, and the first part is unlawful cures rejected. You should not use cures which do not work. Inveterate melancholy, howsoever it may seem to be continuate, inexorable disease, hard to be cured, accompanying them to their graves. Most part, as Monteus observes, yet many times it may be helped, even that which is most violent, or at least, according to the same author, it may be mitigated and much eased. Nil desperandum. It may be hard to cure, but not impossible for him that is most grievously affected, if he be but willing to be helped. And here is one of the cures. I've used that once upon a time when I and my wife celebrated our 100 years anniversary, 50 plus 50. Many and sundry are the means which philosophers and physicians have prescribed to exhilarate a sorrowful heart, to divert those fixed and intent cares and meditations which this malady so much offend. Philosophers refer to psychologists because psychology came out of empirical philosophy. So physicians and psychologists, you should read. The treatment. But in my judgment, none so present, none so powerful, none so opposite as a cup of strong drink. I prefer, of course, wine, but it could be coffee or vodka, mirth, music, and merry company. Melancholy, so 388 years ago, since Burton, nil desperandum. It is not yet lost. The hope has not been lost. I took that picture also yesterday. Two persons, woman and a man, are looking to the sea. It's in southern Helsinki. I think it's important to pay attention to the apple. Anyway, they are sitting there. I took also this picture last night. That is the view, actually, to which they are looking. Nil desperadum, I would say. And now your turn, dear Professor Kirsch.
Can you hear me? Oh, yes.
Yes, they can. Your turn.
Good. I want to thank you for one of the most delightful introductions that I have experienced. That was absolutely delightful. Thank you very much. And thank you for inviting me here. Is this too loud? Can you hear me well? Okay. When I told my son that I was coming here to speak, he's asked me, what kind of talk are you going to give? And I said, well, I'm going to give a placebo talk. And he said, well, Dad, is it going to be a real placebo talk, or are you just going to pretend to speak and see if anyone hears you? And I told him it was double blind, so I didn't really know for sure. So we shall see. February 26th, 2008, a meta-analysis that my colleagues and I had done on antidepressant medication was published in the journal PLOS Medicine. That morning, I woke up to find that our study had become the lead front page story in virtually all of the main daily newspapers in the UK. And then 2 years later, was the subject of a 5-page cover story in Newsweek magazine. And 2 years after that,
the medical community is at war, battling over the scientific research and writings of a psychologist named Irving Kirsch. The fight is about antidepressants and Kirsch's questioning of whether they work.
Somehow, I'd been transformed from a mild-mannered university professor, there he is, into a media superhero or supervillain, depending on whom you asked. What had we done to warrant that kind of notoriety? Well, to tell you that story, I have to go back to 1998, when an earlier meta-analysis was published, a paper that I co-authored with, at that time, my graduate student, Guy Saperstein. And that was a meta-analysis of the published clinical trials on antidepressants. But what I have to tell you about that is that when we published those trials, I really had no interest in investigating antidepressant medication at all. I was interested in the placebo effect. I've always been interested in the placebo effect. It's something that I started researching when I was still an undergraduate student at the university. And then I became addicted to placebo research. Now, when you're addicted, you need help. And some people, when they're addicted to alcohol, they go to an organization called Alcoholics Anonymous. I'm sure you know of that. I tried going to Placebos Anonymous, where the first step was to admit that I really didn't have a problem at all. But it didn't help. I couldn't stop. I couldn't stop researching the placebo effect. And it seemed to me, and it seemed to my student, Guy Saperstein, that there ought to be a placebo effect in the treatment of depression. We assumed there was also a good-sized drug effect. I mean, everybody knew that antidepressants work, and I knew it, and I had a clinical practice, and I was seeing patients in psychotherapy. And in those days, if they were very depressed, I would refer them to psychiatric colleagues to get prescriptions of antidepressants. But it seemed that there ought to be a good-sized placebo effect in the treatment of depression. And the sections from Melancholy that you heard read and saw on the screen just a few minutes ago give you some idea why. Fear comes from the expectancy of bad outcomes, sadness, despair, depression, from the certainty of it. Core feature of depression is a sense of hopelessness. You're in this terrible state of affairs, and there seems like there's no hope of ever coming out of it. As John Teasdale in Oxford once said, some depressed people are depressed about their own depression. And so if you provide the sense of hope that a new experimental treatment might provide, there ought to be some effect. You're countering the hopelessness that's part of depression. So we searched for clinical trials in which depressed patients had received a placebo or no treatment at all. That was important, because if I just give somebody a placebo and they change, that's not a placebo effect necessarily. If you have a cold and I give you a placebo and check 2 weeks later, I bet there'll be close to 100% response, but you'd have gotten the same response if I hadn't given you the placebo at all. So we also had to look for trials in which depressed patients were put on a waiting list, were not given any treatment at all. And we combed the literature for that. Now, where could we find data on depressed patients who had been given placebo? There was only one place. there was only, maybe I should use this instead. Is that okay if we switch to this? There's only one place where you find, no, it's not. Try again. That's fine. That's fine? Okay.
Just keep the mic close to you.
Okay. So the only place you can find data on depressed patients who have been given a placebo is in the drug trials. And that meant that in order to get these data, those on people given placebo, we also had these data. And what does a researcher do when he or she has data?
Calculates.
We analyze it, that's exactly right. And so we did that, and we looked to see how much change there was from before treatment to after treatment in people who had been prescribed, randomized to get the antidepressant drug. And what you're looking at here are effect sizes, not standardized mean differences between before and after, and that's a very good size effect. By conventional terms, that's a very large effect. But then we look at the placebo condition, and that's also a very large effect, and we look at those who receive no treatment at all, it's a much smaller effect. About 25% of the response in the antidepressant drug would have happened even if you had done nothing at all. That's natural history, spontaneous remission, regression to the mean, which is a statistical artifact. That's not a placebo effect. But that left another 50% of the drug response that was a genuine placebo effect. That didn't surprise us, but what surprised us was how small the drug effect was, because that left only 25% of the response as a true drug effect, the difference between the placebo response and the drug response. And that was surprising for a treatment that had been heralded as constituting a revolution in the treatment of depression. So much of a revolution that over the years, psychiatrists had been giving up doing psychotherapy, and instead of having 50-minute psychotherapy sessions, having 15-minute prescription follow-up sessions. When we first saw those data, our first reaction was, we must have done something wrong. After all, everyone knows antidepressants work. What could we have done wrong? Well, maybe we had looked at the trials, any trial we could find where people had been randomized, depressed patients had been randomized to get a drug or not. This is stopped again.
You simply move to your forehead.
Like this?
No, the original, yes. No.
Now? Now, this is, well, is this a placebo microphone?
In the middle position.
Try again. Try now. 1, 2, 3, testing, 1, 2, 3. I can speak pretty loud. That's what I'll do, I'll speak louder. So what we thought was maybe we had looked for any trial at all that was comparing an active drug to a placebo, and maybe some drugs are more effective than others. And maybe by grouping them all together, ineffective antidepressants with effective antidepressants, maybe we're underestimating the real response to the antidepressant and overestimating the placebo effect, underestimating the drug effect. So we went back to the studies. This is before we even sent it off. So the first, as a paper to be published, we went back and we looked at what kinds of drugs were the patients given in these various trials. And some of them were trials of tricyclic antidepressants, older generation antidepressants, and some were trials of SSRIs, and there were some that were trials of other antidepressants, including MAO and inhibitors. And the placebo response accounted for about 75% of the response to the antidepressant drugs, for the tricyclics, and the same degree for the SSRIs, and the same for the other antidepressants. And there was yet a fourth category of drugs that we had not expected to find. These were drugs that were not antidepressants, that in a trial had been compared to placebo for the treatment of unipolar depression. They included lithium for unipolar depression, trials of barbiturates, of synthetic thyroid hormone in patients without a thyroid disorder, and benzodiazepine. Exact same response. I remember looking at these data and one of my reactions being, you know, this would be a beautiful slide to show in a talk. So the question is, what do these active drugs, the tricyclics, SSRIs, MAO inhibitors, lithium, benzodiazepine, barbiturates, what do they all have in common that they do not share with the inert placebo? And I bet you can guess. Side effects. They all produce side effects. And why is that important? Well, first of all, they all little data to back that up. This is a trial of tricyclic antidepressant, imipramine. There's this typically small difference you get between drug and placebo. Here's the difference in the side effects between drug and placebo. Why is that important? Well, imagine that you have been recruited for a clinical trial of an antidepressant. First thing that happens when you're recruited for a clinical trial is you have to give informed consent. And as part of the informed consent procedure, you are told that this trial involves placebos. You may be getting the test drug, you may be getting a placebo, and it's double blind. Well, that's not what double blind really is. So you're not going to know, and your doctor's not going to know whether you're being given the real drug or the placebo. Now, the therapeutic effect for antidepressants, sometimes it takes a while for you to notice any difference. It may take weeks before you feel a difference. There are, however, side effects. They tend to come on more rapidly, and you're told exactly what the side effects are. I have to do that by law, at least in the US. Now, if I were a patient in one of these clinical trials, I'd be wondering, which group am I in? Have they given me the antidepressant, or am I just getting a sugar pill? I don't know, it's double blind. Gee, my mouth's getting dry. My mouth's getting dry. My mouth's getting dry. Hooray! That means I've been given the real antidepressant. I'm in the drug group. I feel better already. Doctors and patients in antidepressant trials, and in trials of other medications as well, break blind. They figure out whether they're getting the active drug or not. Here's the degree that it happens. See, we rarely check that. We usually don't ask patients before we tell them, we break open the sealed envelope. We don't tell them, we don't ask them, what do you think you've gotten? Do you think you've gotten an antidepressant? The drug? Do you think you've gotten the placebo? Here's what happens when you do ask it. Now, by chance, you ought to get 50% guessing, because this is a two-arm trial. They're getting one or the other. In the placebo, among the patients, in the placebo group, about 60% guessed they were on placebo. That's not much different than chance. So they could be just guessing. But look at those in the drug group. 89% of them said, oh, I've gotten the real drug. And that is significant. Among doctors, the rate of guessing is if you want to put guessing in quotes, even in the placebo group. It's not double-blind. Here's another trial. This is a trial on panic disorder with patients being given placebo, a benzodiazepine, or a tricyclic antidepressant, and patients asked, what do you think you've gotten? Chance in this is going to be 30%, right? 33%. 3 different groups. Here's what the placebo group patients guess. Here's what they guess in the benzodiazepine group. Here's what they guess in the tricyclic antidepressant groups. Doctors, they're even better. And the interesting thing here, they're not only can they distinguish drug from placebo, they can tell which drug you're on. How? Side effects. These trials wind up being more double talk than double blind. And breaking blind makes a difference. This is a meta-analysis. And what you have on the bottom are correct guessing. What is the percentage, the accuracy, the percentage of patients on this panel, doctors on this panel, how accurate were they in guessing which group they had been assigned to. And this is the effect size for the drug placebo difference. Here it is for patients, and there it is for blind raters. They know. The more they know, the better the effect of the drug versus the placebo. Unblinding makes a difference. Let me show you one more example of that. This again is a meta-analysis, and we're looking at 3 kinds of clinical trials. In this kind right here, these are comparator trials. There is no placebo. You're told in the informed consent, you're either going to get this drug or you're going to get that drug. There's no chance at all of getting a placebo. Here's the response rate in comparator trials. 33%, these are 3-arm trials, so you've got a 2/3 chance of getting an active drug, but you've got a 1/3 chance of getting a placebo. Here's the response rate to the active drug in 3-arm trials, and here it is in 2-arm trials where there's a 50-50 chance. The greater the likelihood of getting a placebo, the less the response to the active drug. Here's what happens in the 3-arm trials and the 2-arm trials in the placebo group. Greater chance that you're getting an active drug, the greater the placebo response. The difference between knowing that you're getting an active drug and having a 50% probability of having an active drug, that's a 16% difference in response rates. It's about the exact same difference as between drug and placebo in the placebo-controlled trials. So placebos, antidepressants might be functioning like extra strength placebos in these clinical trials. They have a greater effect because the person believes that they are on the active drug instead of thinking they're on placebo or might be on placebo. One way around that is the use of active placebos. That was tried. An active placebo is a drug that should not have any therapeutic benefit for the condition being treated, but produces side effects. Hopefully side effects that mimic those of the real drug. And those are called active placebos. There are 9 trials of antidepressants in which active placebos were used. When you look at the published literature on inert placebos, about 3 out of 4 of the studies show a significant, statistically significant benefit of the active drug. In the active placebo studies, only 1 of the 9 studies showed a significant benefit for the active drug. Well, we published our first meta-analysis in 1998. There was a very popular book in the US then called Listening to Prozac, where Prozac was being offered as a cure-all for everybody, even if you're not depressed. You can make your life better, be happy on Prozac. We titled our article reporting this meta-analysis, Listening to Prozac but Hearing Placebo. And it was very controversial. And one of the critics wrote, "Your analysis derives from a minuscule group of unrepresentative, inconsistently, and erroneously selected articles. What are we to do?" A fellow in Washington, D.C., Thomas Moore, who I'd never met, he wrote to me and said, sent me an email, he said, "I'm aware of the, I'd liked your article a lot, I'm aware of the controversy, read the critiques. I have a suggestion for you. Why don't you replicate your own study on an independent data set? And I'll suggest a data set you can use. Why don't you go and use the Freedom of Information Act to obtain from the FDA, the Food and Drug Administration, data from all of the clinical trials that had been sent to them for the approval of antidepressant drugs." I said, well, that's a great idea. Why don't we do it together? He was in Washington, D.C., so he got the data, made a copy, sent it to us in Connecticut, which is where I was then, the University of Connecticut. 2 separate analyses to make sure we're not making mistakes, pulled them together. He got the data from what at that time were the 6 most widely prescribed antidepressant medications. Now, the FDA data files are particularly important and different from other data sets. For one thing, they are the basis upon which the drugs were approved in the first place. So if there's anything wrong with these data, if the studies were flawed, as many have since suggested, then the drugs should never have been approved in the first place, right? Second important feature of the FDA files is that they include data from all of the adequate and well-controlled studies, ones that they have deemed to have been adequate and well-controlled. And that's very important because, as it turns out, almost 50%, 4 out of 10 of the trials conducted by the drug companies sent to the FDA had never been published. And if you looked at the outcome of these trials, it's clear why they had not been published. When you looked at the published trials, 3 out of 4 show a significant benefit of drug over placebo. If you look at the unpublished trials, that drops down to 12%. Now, we had all of them. We had the published trials. We had the unpublished trials. We analyzed them together, and we looked at changes on what was the primary outcome in all of these trials, the Hamilton Depression Inventory. And we found there was a reasonably good size mean improvement in the drug condition, and a reasonably meaningful good size difference in the placebo group. Now the placebo response was accounting for more than 80% of the response to the active drug. The difference between active drug and placebo in these trials was less than 2 points on the Hamilton Depression Inventory. A standardized mean difference in effect size of 0.32. The Hamilton Depression Inventory, you can get a score on it ranging from 0 to 53 points. You can get a 6-point difference with changes only in sleep patterns and no change in any other symptom of depression. A 2-point difference is not clinically meaningful, and you don't have to take my word for it. The National Institute of Health and Clinical Excellence, which is, their acronym is NICE, a very nice organization, and they are responsible for establishing treatment guidelines for not just depression, but all disorders for the National Health Service in the United Kingdom. They looked at our data, they looked at other data, they did their own meta-analysis, and they established a priori a drug placebo difference on the Hamilton of 3 points as being clinically meaningful. An effect size of 0.5 as being clinically meaningful. So you have to understand that there's a difference between statistical significance and clinical significance. Statistical significance deals with the question of whether an effect is real or it's just what's the odds are that it would have occurred just by chance. It doesn't tell you in and of itself anything about the size of that effect. Clinical significance addresses the question of how meaningful is this effect? What kind of difference might it make in somebody's life? Let's take an example. Imagine a study has been done on 500,000 people and has found that smiling increases life expectancy by 10 seconds. With 500,000 subjects, I can virtually guarantee you that that 10-second difference will be statistically significant, even though clinically irrelevant, meaningless. Well, we published those data in 2002, and one of the criticisms that we encountered was the patients weren't depressed enough. You see, if you give antidepressants to mildly, maybe even moderately depressed patients, yeah, some of them will get better, but you won't be able to distinguish the improvement from them. You give them placebos, it'll have the same effect. But you know, we see really severely depressed patients in our practices, and they're the ones who show the real benefit of the antidepressant drugs.
Is that an original commercial?
I don't think so. So what were we to do? We went back to our own data set, and we looked at what was the mean severity at baseline of the patients in each of these trials. And we used the American Psychiatric Association criteria for severity. We found one trial of patients who are moderately depressed at baseline. Only one trial. And in that trial, there was no difference between antidepressant and placebo. It was one of the early trials of fluoxetine, Prozac. After that, they stopped including mildly and moderately depressed patients. There were no trials with severely depressed patients. All of the rest of the trials were on patients who were very severely depressed. And they still didn't meet this three-point criterion that had been proposed by NICE. We did find within that group, there were a small group of patients. There's no more severe category than the very severe in this categorization system, but at the very tail end of it, there were a small group of trials of patients at the severe end of the very severe, let's call them the extremely severely depressed patients, who did surpass the NICE criterion in terms of drug placebo differences. Still a small difference, about 4 points, but it passed the NICE criterion. What's that? How does that relate to what's happening in, this is working fine now, isn't it? Can you hear me now? Good, we'll do it this way. How does this relate to clinical practice? Well, here's the level of severity of patients in clinical practice, outpatients, who are diagnosed with major depressive disorder. These are their baseline Hamilton Depression Scale scores. About 10% of them are at the level of depression that they might get what NICE considered clinically significant benefits. That means that 90% are not getting a clinically significant benefit from antidepressant medications. We published those results in 2008, and one of the things the critics said is the patients were too depressed. That was in an editorial in Nature Review's Drug Discovery. What were the editors thinking of? They pointed out, they said, look, you've got trials with patients who are moderately depressed. Clearly, it doesn't work for them. And you've got people who are very severely depressed, and it doesn't work for most of them. But you haven't got any trials on mildly depressed patients or on severely depressed patients who are more severely depressed than the moderately depressed, but not as severely depressed as the very severely depressed. Maybe it works for them. I guess their hypothesis was that it would be something like this. I call that the Loch Ness Monster hypothesis. So what are we to do now? Well, I guess we could have tried to find more data and do a third meta-analysis on a new data set, but we didn't have to, because a group of researchers at the University of Pennsylvania did their own independent replication using patient-level data from 6 clinical trials, none of them having been included in the FDA data that we had, looking at people who were mildly, moderately, severely, or very severely depressed, and finding the exact same thing that we found. About 10% would have passed the NICE criterion for baseline severity, the rest not. And so the critics said, well, the NICE criteria are arbitrary. And you know they are right. The NICE criteria are as arbitrary as the criterion of 0.05 as a level for statistical significance. They're as arbitrary as saying that a clinical response is a 50% reduction in symptoms and not a 49% reduction in symptoms. They're as arbitrary as saying remission means you've got
less than 8 points rather than 8 points or more on the Hamilton Depression Inventory at outcome. So what might a non-arbitrary criterion look like? My colleague Joanna Moncrief pointed out to me, well, you know, there are data that would allow us to answer that. And she called my attention to a study that had been done by Leucht and his colleagues in 2013, using raw data of 43 clinical trials involving more than 7,000 patients. And in these trials, in addition to having scores on the Hamilton Depression Scale, they also had clinician ratings of improvement. Clinician ratings of improvement, the Global Clinical Improvement Scale, rates people into 7 categories, from very much worse to very much improved. And now what they did was a lovely thing. They took each of these ratings. What was the mean change on the Hamilton score of people who were very much worse? What was the mean change on patients who were much worse? What was the mean change of those who were minimally worse, and so on? As it turns out, a mean change of 3 points improvement on the Hamilton is exactly the mean change that you get in people who are rated by their clinicians of not having changed at all, of having shown no change in depression. It's a level of change that's not only clinically meaningless, it's clinically undetectable by treating clinicians. One would think, if you want to have now a criterion for clinical meaningfulness, it should be a level of change that you get where a patient says, well, this person's at least minimally improved. How much change on the Hamilton Depression Inventory corresponds to a clinician rating of minimally improved? 7 points. Nobody, no clinical trial shows a drug placebo difference that comes anywhere close to that, no matter what the level of severity of the patient's depressions are. Now we look at our data again in terms of a non-arbitrary, empirically derived criterion of clinical meaningfulness, and you can see no one's getting a clinically significant benefit. The last resort of the critics is what we might call the true believer phenomenon. One very distinguished professor wrote, well, antidepressants work. Everybody knows they work. And another critic wrote, clinical practice plus millions of content patients can't be that wrong. Well, the history of medicine is replete with treatments that have worked for millions of content patients. And that is why we don't use patient reports as our criterion for whether a chemical makes a difference. We do clinical trials. And when you do clinical trials, everybody gets the same results. Everybody. Here are the results of 6 clinical meta-analyses. One of them, second one, Futenlakis and Mueller, among our harshest critics, trying to find the flaw in our data analysis. And here's what they get. And I want to draw special attention to this last one. I haven't put the scores up on the board. Brand new meta-analysis, not yet published, by a senior statistician at the FDA, using all of the data of all the clinical trials that had the Hamilton Depression Inventory that were sent for approval to the FDA, patient-level data on more than 23,000 patients, 92 trials, and what do they get as the drug placebo difference? The exact same thing that we got on our 6 antidepressant drugs. The drug placebo difference in these trials are small. Here's what the then director of the FDA Psychiatry Products Division had to say about that on the program 60 Minutes.
The data we have shows that the drugs are effective.
But what about the degree of effectiveness?
I think we all agree that the changes that you see in the short-term trials, the difference between improvement in drug and placebo, is rather small.
I love the look on her face when he says that. We all agree the difference in improvement between drug and placebo is rather small. In fact, it's so small that clinicians cannot detect it as any change at all. And to not see how small it is, you have to hide your head in the sand like an ostrich or a drug company sales representative. And these are in trials that are biased towards the drug. First of all, they're all industry funded. And here's what we know about industry funded drug trials. About 3 out of 4 of them show a significant benefit for the manufacturer's product. In trials funded by independently, not by a drug company, that shrinks to 50%. And in trials funded by a competitor of the drug, as in comparator trials, that shrinks to about 1 out of 4 trials. It's biased because placebo responders are routinely screened out. First week or two, and most of the trials 2 weeks, everybody is put on placebo. Single blind. Patients aren't even told there's a chance they might be on the real, that there's no chance they'll be on the real drug then. A little failure of informed consent. Everybody's put on placebo, and anyone who responds, goes into remission, is kicked out of the trial. The rest are randomized to drug or placebo. Patients who are unlikely to show a drug effect are screened out. Screen out the mildly depressed, the moderately depressed, previous non-responders, chronically depressed patients. And it was because of that that the most expensive clinical trial ever done was undertaken. It's called the STAR-D trial, cost of $34 million. And the aim was to see what is happening in real clinical practice. Let's get rid of these exclusion criteria. Let's not use placebo at all in it because, after all, in the real world, no one thinks they might be getting a placebo. Let's not have volunteers. Let's not advertise for patients. Let's just take patients as they come in to a large number of clinical sites and ask them if they would mind being in this clinical trial, and they're going to get the same drug. If the drug doesn't work, they'll be switched, and so on. As it turns out, almost 80% of the patients that went into the STAR-D trial would have been excluded from a conventional clinical trial. So let's look at their results. We need to think about what we're going to compare those results to. Remember, go to the next, there we go. Remember that in the STAR-D trial, there's no placebo. So the appropriate comparison would be the comparator trials, where you know you're getting an active drug, you don't think you might be getting a placebo. In published comparator trials, you get almost a 15-point reduction in depression scores in comparator trials. What do you get in the STAR-D trial? 6.6 point reduction. No placebo, so we don't know how much of that is a placebo effect. However, there's another trial that can give us an idea. And that's a trial that was done in 2013 by Barber and his colleagues in New York. It was a very well-designed trial, 16-week trials. Most efficacy trials are 4 to 8 weeks because too many people drop out if you make them longer. The STAR-D trial was 14 weeks. This was 16 weeks. People were randomized to either sertraline, it's an SSRI, placebo, or psychotherapy. They used a group of patients that were very similar to the STAR-D patients, the people that would not, by and large, would be excluded, not be in conventional clinical trials. And they did this nice thing. At week 8, people who didn't respond to the SSRI were, as they might be in clinical practice, switched to a different antidepressant, to venlafaxine. And to make sure that things were all equal, patients in the placebo group who didn't respond by 8 weeks were switched to a different placebo. I love that part of the design. The results, that's what you get in the drug group, about the same as you got in the STAR-D drug trial, and here's what you get in the placebo group. And it doesn't matter which antidepressant you take. You may recall this slide from earlier when we found that, and I thought, oh, what a nice slide it would make, and I thought, what a coincidence. Turns out not to be a coincidence at all. Now, it could be that that data were because, well, some people needed tricyclics and other people needed SSRIs, and so, you know, in clinical practice, we switch from one to another. Maybe that's what would make a difference. Here's the one meta-analysis I know of clinical trials in which people were randomized, people who did not respond to an initial antidepressant were randomized to either be switched to a different one or to be kept on the same antidepressant. People who were switched, 34% now respond. People who are kept on the same antidepressant, 40% now respond. Switching does not make a difference at all. And you can look at head-to-head comparisons of an SSRI with other antidepressants, an NDRI with other antidepressants, Tricytes, et cetera. And here's what you get. And that's without considering tianeptine. How many of you know what tianeptine is? Good. Tianeptine is a drug that has been approved in France by French regulators and prescribed in other countries as well as an antidepressant. It is a very unusual antidepressant. Instead of being an SSRI, a selective serotonin reuptake inhibitor, it is an SSRE, a selective serotonin reuptake enhancer. It's supposed to chemically do exactly the opposite of what SSRIs do. Instead of increasing the amount of serotonin in the brain, it's supposed to decrease it. If there's any truth to the serotonin theory of depression, then SSREs like tianeptine ought to make depression worse. And here's what actually happens. What do you call pills, the effects of which are independent of their chemical composition? I call them placebos. So how did these drugs get approved? Well, in the US, the way they got approved is as follows. You have to look at the criteria for drug approval by the FDA, which is you have to have 2 clinical trials showing significant difference, statistically significant difference, between drug and placebo. There's no limit to the number of trials you can run in order to get those 2 significant trials. As one FDA reviewer said in the proceedings on one of the drugs that I was able to read and obtain, well, they could have just kept running trials till the cows came home. And then when they get the two that are significant, they just come to us and they get approval. 50% of the trials are negative. Negative trials don't count. They're not even mentioned. The existence of them are not even mentioned in drug labeling. So I'll tell you, such and such, antidepressant X, the efficacy of it has been established in 2 clinical trials, with no mention of the 5 clinical trials which showed no benefit whatsoever. And the clinical significance, the size of the effect, is not considered. So how should depression be treated? Well, some people have suggested maybe we should prescribe antidepressants as active placebos. After all, you get the placebo effect. But here's the problem. You have to look not only at the benefits, but also at the risks. Antidepressants are active drugs. They have a lot of side effects. With the SSRIs, side effects range from 70 to 80% of sexual dysfunction, treatment-emergent sexual dysfunction affects from 70 to 80% of patients put on SSRIs. Here are the data, drug by drug. This is what you get as treatment-emergent sexual dysfunction on placebo. Here's what you get on most SSRIs. For most patients, when they get off of the SSRI, they recover their sexual functioning. About 30% do not. That has now been labeled by the Kinsey Institute as SSSD. PSSD, that's it, I knew something was wrong. PSSD, post-SSRI sexual dysfunction. You get 30 to 50% who try to go cold turkey, as it's called, just stop taking their antidepressants. They don't get withdrawal symptoms. And it's not just the patient. If the patient is on antidepressants and has a baby, 30% of the babies born to depressed women on antidepressants are born in withdrawal. They show the same neonatal abstinence syndrome that's shown in the children of mothers who are addicted to amphetamines, morphine, heroin. Other risks. Among children and young adults, an increase in suicidal behavior, increase in violent crime convictions, violent crime arrests without convictions, nonviolent crime convictions, injuries from accidents, emergency treatment for alcohol intoxication. This is from a very recent study, large-scale study done in Sweden. In the elderly, there's an increased risk of stroke, an increased risk of death from all causes. Among pregnant women, an increased risk of miscarriage, and if the mother does not miscarry, in the babies, increased risk of birth defects, persistent pulmonary hypertension, and autism. And this has been linked also to first trimester antidepressant use when the mother may not know that she is pregnant. For everyone, there's an increased risk of type 2 diabetes and an increased risk of relapse. People find this surprising. They say, no, look, these drugs prevent relapse. Here are the data that show it to you. They do what are called relapse prevention trials. They work like this. Anyone who's responded to the actual drug is now re-randomized to either stay on the drug or be switched to placebo. Those who are switched to placebo show close to a 50% relapse rate. Those staying on the real drug only show a 23% relapse rate. That leaves somebody out. What about people who got better on the placebo? What if you just leave them on the placebo? What's their relapse rate? Oh, about 20%. About the same as people who are kept on the drug. What's the difference between those who are in the switch from drug to placebo or kept on placebo? The only difference is whether they were on the drug during this first 4 to 8 week trial. there's the increased risk of relapse. And if you don't believe those data, look at the NIMH Collaborative Research Program comparing cognitive behavior therapy, relationship therapy, imipramine, a tricyclic, and placebo. Their data on relapse at 18 months on CBT, on interpersonal psychotherapy, on imipramine, and on placebo. Those on imipramine had a significantly higher rate of relapse than the others. You can also look at it in terms of number of weeks, average number of weeks before the reemergence of depressive symptoms. CBT, imipramine, placebo. And if those data aren't enough to convince you, look at this trial in which depressed patients were randomized to either be put on an SSRI, an exercise program, or given the combination of exercise and an SSRI. At 4 months, the remission rates were equal, not significantly different among the three groups, and actually those are very good remission rates, much higher than you usually get. What about 10 months? People could stay on their SSRI, they could stay in their exercise program. It's just 10-month follow-up. How many of them relapsed? Rate of relapse on the SSRI was 38%. In the exercise group, it was 8%. But what happens if you combine the two? Went back up to 30%. So, go back one. Adding an SSRI to the exercise program quadrupled the rate of relapse compared to just being in the exercise program alone. It creates relapse. Now, is exercise a placebo? Maybe. But consider the side effects of antidepressants and compare them to the side effects of exercise. And consider which placebo you might rather have. So maybe we should prescribe placebos. But there's a problem, you know. If I know it's a placebo, will it still work? Well, I guess we could have problems prescribing placebo, but fortunately, we don't have to. We have a lot of different treatments for depression. Not much difference between antidepressant and placebo. We want to at least match and hopefully surpass placebo pills. Being put on a waiting list does not do that. Standard care actually just comes close about the same as placebo, even though standard care usually includes antidepressants. Psychotherapy gives you the same short-term benefit of antidepressants, but without the significant relapse. Adding an antidepressant to psychotherapy doesn't give you any significant additional benefit. Physical exercise gives you the same benefit without the risk of additional relapse. Acupuncture gives you the same benefit. So what should be our guidelines for treatment choice? I will suggest this. When treatments are equally effective, prescribe the safest. When they are equally safe, prescribe what the patient prefers. And in patient survey after patient survey, 34 patient surveys asking depressed patients, would you prefer to have an antidepressant or to be in psychotherapy? 3 out of 4 would choose psychotherapy. So we don't have to give placebos, but I have to admit, I wish we could. Well, I had a dream once. I was back in the UK and I woke up and I opened my favorite UK daily newspaper, The Dependent. Oh, that should be Independent. And my dream was I read that placebo had been approved by the FDA in doses ranging from 1 to 40,000 milligrams. And I thought, well, you know, if the FDA approves it, then in the US and New Zealand, not anywhere else that I know of, we could advertise it. Because in the US, they advertise on television prescription medications. They have pictures, they have antidepressants, they have the pictures of usually women running through the fields of flowers. It was for one antidepressant or another. And so I wondered, what would a placebo advertisement look like? And I imagine it would look something like this. Prevaricaine, a genuine placebo medication, tested in more clinical trials than any other treatment. So powerful, it's the standard by which all other medications are tested. So effective, it can be used in the treatment of thousands of ailments, safe enough to be given to infants, the elderly, and pregnant women, but there's a warning. It may put you off of medications that do have side effects. Remember, if it's a placebo, you can believe in it. Thank you.
Okay, thank you, Irving. It was a wonderful presentation, and also you left us great time for discussion, not only after all the presentations, but within our time schedule. We have until 1:45 before we serve coffee and tea. So, direct questions and discussion with Professor Kirsch. Please.
I have one question.
Okay.
What is there in placebo? What kind of things you place in placebos?
That's a good question. There are different things that are used. They usually are not sugar. They should be always listed, and they are not always listed. So with injections, it's often saline. Sometimes lactose is used, should not be used in irritable bowel syndrome studies, obviously. They are supposed to be inert ingredients. They should routinely be listed as what those ingredients are. I have to tell you something that I find fun. One of the studies that I didn't put into that we've done was a study of irritable bowel syndrome in which we used an open label placebo. We told people, this is a study of a novel mind-body treatment for irritable bowel syndrome, and it involves the use of placebo. You know what placebo is? It's like a sugar pill. It has no active ingredient. But we think that you might be able to respond to it the same way that Pavlov's dogs responded to the sound of a bell after being associated. So you've had effective treatments, and they've always been given to you in the form of pills or injections. And that might be a way of triggering your own self-healing capacity. And we know that placebos are effective in irritable bowel syndrome, so what we'd like to do is give you this placebo, and we want you to take it, two pills twice a day. So 2 pills in the morning, 2 pills in the afternoon. And gave them pills. We had half the patients were given pills and half were not. And they came back, assessed it, we published the study, and indeed, open label placebo worked. And it worked very well. So we are now doing a replication. We've just gotten funding for a large-scale replication of this. We're comparing, among other things, open-label placebo to double-blind placebo. And since it was the investigational drug, we had to get FDA approval for placebo as a new investigational drug, and we got it.
Okay. Other questions? Yes?
Do I just shout or?
Let's use the microphone so that everyone can hear. Okay.
Thank you very much. So I work in mindfulness research, and MBCT has been approved for recurrent depression in NICE criteria, I think, in the UK. So thinking about all these like treatments that don't have noxious side effects, like mindfulness or exercise or psychotherapy or nutrition treatments, maybe like, do you know if there are studies where the effects of these kinds of treatments have been combined and maybe trying to come up with some sort of synthesis of these? And another question relating to this is, how do you think or hope depression would be treated in, say, 2040?
They're both excellent questions. I know, of course, that mindfulness meditation has been combined with cognitive behavioral therapy, and it's mindfulness-based CBT, it's called, and there are outcome studies on that, and that's what led NICE to include mindfulness as an approved treatment for depression. One of the problems, of course, is that it costs a lot of money to do clinical trials, and the drug companies are not going to do clinical trials on the alternatives. So as a society, we need to fund outcome studies on various alternatives and combination treatments from depression. I predict, fortunately I won't be around to see if the prediction is right or not, I predict that 50 years from now, we will look back at what David Healy has called the antidepressant era, and I'm not sure what we'll be doing then instead. I bet things like mindfulness and exercise will be part of the things that are being done to help people with depression, which for most people I think is a normal response. I don't consider it an illness. I think it's a normal response to a terrible state of affairs. I think we will be looking back at this era and will regard antidepressants treatment as the way we now regard bloodletting as a treatment. That's my prediction. I should mention something else. I remember a few years ago, I don't know if you know about this, but in the US, the diagnosis of psychiatric disorders is done with a thing called the DSM, the Diagnostic Statistical Manual. They are now in their 5th edition. And they used to have, in diagnosing major depressive disorder, they used to have what was called the bereavement exclusion. So if your depression was preceded by the loss of a loved one, you were not considered mentally ill if you showed the symptoms of depression. In DSM-5, they have removed that. So if you lose a loved one and you're still depressed 2 weeks later, you are mentally ill. Isn't that barbaric?
Okay. Comment here or question?
Thank you for a really interesting talk.
Thank you.
I was wondering about the role of the drug regulators, because one would hope and would think that the drug regulators would be looking out for our interests. Could you say something about their role and how it has come to be that they can work in such a short-sighted manner in approving drugs that are not only seem effective instead of being actually beneficial?
Yes, and thank you for that question. Back in the era of the first Bush presidency, so the Bush the father, I think he's called, there was a change in regulations. FDA used to be publicly funded completely. A law was passed allowing direct drug company funding of the FDA. This was done in order to speed up the approval process stipulation in the law is that none of that funding can be used for safety monitoring, only for speedier approval. The drug companies now provide 40% of the funding for the FDA. This has led to a change in outlook within the FDA, a change in the atmosphere within the FDA that was testified to in congressional hearings and written about in the New England Journal of Medicine. One FDA employee was admonished by his supervisor that the drug companies are our clients. And he responded saying, I thought the American people were our clients. Now, that's the FDA. Here we are in the European Union. And the bad news is that 70% of the funding for the European regulators comes directly from the drug company. And in the UK, thanks to Margaret Thatcher and a law published under her regime, that goes up to 100%. There's a saying about the foxes guarding the hen house that may be appropriate in this case.
Okay, thanks. Yes, please.
Thanks for your great work. You also used this term placebo, but doesn't it disguise the true nature of phenomenon, the psychological effect? Other doctors and researchers use this more specific or some kind of truer concept, psychological effect in studies.
Yeah. I do believe in psychotherapy, and I believe in mindfulness, and I believe in physical exercise, and but I also have to remind you that although not all non-medical treatments are placebos, exercise may be a placebo, it may not. Placebos are psychological treatments. We don't want to deceive patients. I don't think we should, but we also should not rule out treatments that are effective because of the same things that produce an effect, a placebo effect. And you think about why you use a placebo. You use a placebo in medical trials, in pharmaceutical trials, in order to separate the chemical effect from the psychological effect of treatment. Psychotherapies are psychological. Mindfulness is psychological. We don't want to rule out the placebo effect. As two of the major components of the placebo effect are expectancy of change, and the therapeutic relationship. Those are legitimate, critical psychological principles that are legitimate psychological factors and part of psychotherapy. It's fine and right that major components of psychotherapy should involve a warm, caring, therapeutic relationship and a positive attitude towards change. One of the things that I found beautiful in the introduction was I didn't know about I knew about the Burton's treatise, but I didn't ever read those quotes about expectancy and hope, and they are what we try to instill as psychotherapists.
Yes, thank you. Yes?
I was wondering if you know anything about the clinical practices of psychiatrists and if there has been any change in the recent years, because your studies sound pretty significant, but I wonder if doctors are responsive to that information or not.
My impression is that some are and some aren't. There was a poll done among physicians shortly after the 2008 study came out in the UK, where it got such notoriety, and 55% of them
said that they would now change their prescribing habits on the basis of that. The UK government, based not just on my research, but on NICE's research, undertook a training program to train 10,000 new therapists to provide psychotherapy for the treatment of depression. And that program is well underway. On the other hand, prescribing rates of antidepressants continue to go up, and not just for depression and anxiety disorders. They are very often prescribed off-label, meaning for things for which they have never been approved. There was a recent epidemiological study looking at patients who are currently taking antidepressant medication and looking at their lifetime incidence. Are they now or have they ever suffered from either a major depressive disorder or an anxiety disorder? And the conclusion was that 38% of them had never had a major depressive disorder or an anxiety disorder, and yet we're now on antidepressants. SSRIs in particular are doled out like candy by some physicians, by general practitioners. I have twice been offered SSRIs. Once when I was complaining about having trouble sleeping, so this is going to be the treatment to help me sleep. No evidence for its effectiveness at all. And the other was a few years back. I was on a very heavy teaching schedule, speaking schedule.
I know your week here is very heavy too. So.
Yes, but this was.
You should consider.
This was over a 2-month period when I'd been invited to give 14 talks in 6 different countries. About midway through, I was consulting a physician about a totally different matter, and mentioned that, you know, I'm back in town, but I'm heading up here, and it was really a stressful schedule. He said, wow, that sounds way too heavy. You probably shouldn't undertake that much. I said, no, you're right. That's too stressful a schedule. He said, well, I can see it. You're obligated now, but for the meantime, how would you like I could give you a prescription for citalopram. Hey, he was serious. He didn't know what I did for a living. I've had a neighbor whose pet dog died, and the first thing that his physician did was to offer him an antidepressant. Very first thing. I had a good friend who was suffering from a lumbar muscle spasm. I was offered an SSRI. I don't know on what basis.
Hi. I was very interested to find here.
There you are. Okay.
We found that there was an effect when you used a study where you had an open label placebo, because I thought the reason placebo works that people think there's an active ingredient in the pill that you give them. So I was wondering if there has been, or if you're thinking about doing a study where you compare an open label placebo with a blind label placebo and tell the difference.
Well, actually, that's part of the study that we're just starting now, that we just got funded for, and we had to get FDA approval for our open label placebo, and we've gotten it. And that's a study on irritable bowel syndrome. We've got 5 groups. So one group is a no treatment, waitlist control group, standard care. And then half of the people are going to get placebo, and half of the people are going to get peppermint oil, which has shown benefits above placebo in double-blind trials, and half will be told what they're getting, and for half it'll be double-blind, and we'll see what happens. Some people in our group have done a pilot trial with mildly and moderately depressed patients same level of depression that in that early fluoxetine trial, doing open-label placebo as a feasibility study, and in that study, rather small, got the same response curve that you got in the both placebo and fluoxetine Prozac in the trial that they had submitted to the FDA. So we'll see, and I know my colleagues are applying for a grant to try and get funding to turn that into a regular clinical trial. There's an open label placebo trial taking place right now in Portugal for lower back pain, and we'll see how that works. But we don't need even open label placebo. We have other alternatives and psychological and physically based alternatives that are safe and effective for many conditions. Lifestyle changes. A lot of things can be improved by lifestyle changes, healthier diets, better exercise, more physical exercise, and so on.
Yes. Yep.
One of the cures which Burton prescribes is music.
Music, yeah. That's good for everything, of course.
Effects of that.
In light of your studies, how do you think that we should carry out children's treatments of depression?
Oh, is that such a good question? Certainly, 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 we should never put a child on an antidepressant. We know that it increases the risk of suicidal behavior. We know it increases, with adolescents, the risk of violence towards others. You don't want to be monkeying around with the changes that we don't know what in the long term these things are doing. And the thing that's really terrible, I think, is when I see adults, and even worse when it's kids, being put on one antidepressant, then switch to another. Then you add an adjunct drug, and then that's still not working, so you put them on 3 drugs, then you add a 4th drug, and this combination of drugs has never been tested in anybody. And who knows what you're doing monkeying around with these people. I would say the same kinds of alternatives that work for adults, one should deal with children. Look at what's going on in their life. What may be the causes of the frustrations and the hopelessness and the anxiety that they are feeling? Find someone who can help talk to them in a way that might be able to bond with them and work with them in ways that will be helpful. Warm, loving compassion. Those are things that can make a difference.
Yes, thank you.
Thank you for an inspiring lecture. This is more of a comment than a question, but I work as a teacher in Applied University of Sciences, and I teach psychology, mainly to the nurses, and I feel somewhat it's hard to show these results that you show here. Maybe here's what has happened to Aku and this kind of things, but still, I just wanted to say that it's very nice and encouraging me to explain about these things to nurses, so thank you.
Thank you very much.
Yes, that's true. It puts us as all those of us who work as psychologists in healthcare, where both adult and also younger clients are on medication. Of course, it's put on a dire ethical position not to be disloyal to the team. This is a difficult thing. Would you have any wise advice for that? No, not to be completely disloyal, but still be ethical.
Well, it can be a hard question. I think the first loyalty has to be to the people we're treating. And hopefully try and help our colleagues to maybe rethink some things and be open ourselves to new data as they come up. I've changed my mind many times on the basis of data. I've been as wrong as many times as I've been right, and the data are the things that you have to trust.
And I do see some change among psychiatric colleagues. One such change was I had a neighbor living across the street from me. I felt very fortunate that he was a musician because I play music and my children play music, and he was a violist, and oh, it was so exciting. Had someone to play with. We would get together and play chamber music, and he moved away. I said, I wonder who's going to move in. I'm going to miss him a lot. And a new family moved in. The fellow's a psychiatrist, and met him outside. Seemed like a wonderful guy, so suggested we get together. And I said, I have to warn you, because it turned out he worked at some of the places where I knew some psychiatrists. I have to warn you, you know, some of my work is controversial and deals with psychiatry. And he says, oh, yeah, I know. He says, actually, I'm on your side. And what I do now is primarily psychotherapy and like to avoid prescribing. So there are some shifts back, I think, that are taking place, little by little.
Time for one more question before coffee and tea. Please. If not, then we'll have a coffee and tea break until 2:10. And before you go, remember that the seminar will go on, and Irving Kirsch will stay with us until 4 o'clock. So he will discuss all the matters with us. And the rest of the, after the coffee and tea break, the presentations will be in Finnish, but we'll translate the contents to Irving in English. Okay? Until 2:10.